Welcome to Pediatric Ophthalmology and Strabismus, Chapter 4, where we shift our focus away from eye movements themselves and start thinking about how the brain uses the visual information it receives. Up to this point, we've talked a lot about alignment and motor control. In this chapter, we're going to zoom out and ask a different question. Once the eyes are pointed somewhere, how does the visual system combine, interpret, or suppress what each eye sees? This chapter is all about sensory physiology and sensory pathology. That means we'll cover how normal binocular vision develops, how the brain fuses images from two eyes into one percept, and what happens when that process breaks down, especially in the setting of childhood strabismus. As we move forward, keep this framing in mind. Many of the motor findings we see in clinic only make sense once we understand the sensory adaptations happening behind the scenes. This slide highlights a few core ideas that frame the entire chapter. First, diplopia in a child with otherwise normal alignment isn't always abnormal. In some cases, it reflects physiological diplopia, which is a normal feature of binocular vision rather than a sign of disease. Second, when strabismus occurs early, the developing visual system adapts. Anomalous retinal correspondence and suppression are protective mechanisms that reduce or eliminate diplopia, even though they sacrifice normal binocular function. Finally, monofixation syndrome is a common clinical pattern to recognize. These patients have preserved peripheral fusion but poor bifoveal fusion, and this is often associated with mild amblyopia and a small-angle strabismus. To understand normal binocular vision, we have to start at the level of the retina and perception. Any stimulation of the retina, whether it's caused by light, pressure, or even electrical activity, is interpreted by the brain as light and is perceived as coming from a specific direction in space. That directional perception isn't random. Each retinal point carries a fixed directional value, and that value stays the same regardless of how the retina is stimulated. The visual axis helps anchor this system. It's the imaginary line connecting the point of fixation to the fovea. When a person is using central fixation, that visual axis is experienced as pointing straight ahead, which becomes the reference point for how all other visual directions are judged. Now we can build on that idea and introduce retinal correspondence. Retinal correspondence refers to how paired retinal areas in the two eyes are linked perceptually. When corresponding retinal points are stimulated at the same time, the brain interprets that input as a single object located in one egocentric direction. If instead stimulation falls on non-corresponding or disparate retinal points, the brain assigns two different visual directions to that input. That mismatch is perceived as diplopia. In normal retinal correspondence, the most important pairing is at the fovea. The foveae of both eyes correspond to each other, which is what allows precise binocular alignment and single vision when fixation is central. Once retinal correspondence is established, we can extend it into three-dimensional space using the concept of the horopter. Retinal points that are the same distance from the fovea, whether to the right or left, or above or below, are considered corresponding points between the two eyes. Objects in space that stimulate these paired points are perceived as single. The horopter is the collection of all such points in space that stimulate corresponding retinal locations. In theory, this surface forms a precise geometric circle that passes through both nodal points of the eyes and the point of fixation. That idealized circle is called the Vieth-Muller circle. In reality, however, what we actually perceive as single vision lies on a slightly curved surface rather than a perfect circle. This real-world surface is referred to as the empirical horopter. Now we can refine the horopter further and introduce Panem's area. The horopter exists in both the horizontal and vertical planes, but because the eyes are separated horizontally, the true three-dimensional horopter isn't a single flat surface. Instead, it's better thought of as a combination of a curved horizontal line and a sloped vertical line that intersect at the point of fixation. Importantly, the visual system is tolerant of small mismatches between the two eyes. Panem's area defines the zone around the horopter where slight retinal disparities are still fused into a single percept. Objects that fall within this area are seen singly, even though they don't stimulate perfectly corresponding retinal points. When objects fall outside Panem's area, physiologic diplopia occurs. Objects farther than the fixation point produce uncrossed diplopia, while objects closer than fixation produced crossed diplopia. A healthy child without strabismus may notice and even describe this phenomenon, and it remains a normal feature of binocular vision. Let's break this picture down in a simple way. Imagine your eyes are trying to look at one spot straight ahead. That's the fixation point in the middle. When both eyes are lined up on that point, the brain is happiest because it knows exactly where things are. Now picture a curved sweet spot in space where things look single instead of double. That curved line is called the horopter. Around that line is a small cushion called Panem's area. As long as an object falls inside that cushion, your brain can still merge the two eye images into one, even if they're not perfectly matched. That's also where depth perception, or stereopsis, lives. If an object is farther away than the fixation point and outside that cushion, your brain can't fuse it anymore, so it looks double. That's uncrossed diplopia. If an object is closer than the fixation point and outside the cushion, it also looks double, but in the opposite way. That's crossed diplopia. The key idea is this: seeing double in these situations doesn't mean something is wrong. This is normal binocular vision working exactly the way it's supposed to. This slide is showing you how to feel physiologic diplopia in your own body. Start by holding one finger straight out in front of you at about reading distance, right in the middle. Line that finger up with another object that's farther away, also straight ahead. First, look at the far object and really focus on it. When you do that, your finger will look doubled. If you close one eye and then the other, you'll notice that the doubled finger appears crossed. That's crossed physiologic diplopia, and it happens because the finger is closer than where you're focusing. Now switch your focus to the finger. When the finger is clear and single, the far object will look doubled instead. If you alternate closing each eye, the doubled far object will appear uncrossed. That's uncrossed physiologic diplopia, and it happens because the object is farther away than your point of fixation. The point of this exercise is to make Panem's area real. It shows that crossed versus uncrossed diplopia isn't abstract theory. It's a normal, predictable result of where objects fall in space relative to fixation. Let's use this diagram to connect the experience you just had with what's actually happening on the retina. In the left picture, the object labeled P is closer than the fixation point, which is labeled F. When you keep your eyes locked on the fixation point, the closer object lands on the temporal retina in both eyes. Because the brain expects the images to line up differently, that input is interpreted as crossed diplopia. In the right picture, the object is farther away than the fixation point. When you fixate on F, the farther object projects onto the nasal retina in each eye. That pattern leads to uncrossed diplopia. So the rule is simple and consistent. Objects closer than fixation cause crossed physiologic diplopia, and objects farther than fixation cause uncrossed physiologic diplopia. This diagram just shows the wiring that explains why the finger experiment works the way it does. Now we can talk about fusion, which is what the brain does with the two images once they reach the cortex. Fusion is the cortical process of combining one image from each eye into a single percept. For this to work, the two retinal images have to be similar enough in size and shape for the brain to match them. At the center of vision, near the fovea, fusion is very precise. Central or macular fusion tolerates only minimal differences between the two images, because the receptive fields there are very small. If the images differ too much at the macula, the result is diplopia. In the periphery, fusion is more forgiving. Peripheral receptive fields are larger, so the visual system can tolerate greater image differences and still fuse them successfully. Classically, fusion is divided into sensory fusion, motor fusion, and stereopsis. And a useful clinical pearl is that, even with perfect ocular alignment, distortion at the fovea, such as from an epiretinal membrane, can disrupt central fusion and cause diplopia. This slide narrows fusion down to its sensory component. Sensory fusion depends on an innate and highly organized map between the retinas and the visual cortex. From birth, the brain is wired to know which retinal locations belong together. When images fall on corresponding or nearly corresponding retinal points, the cortex combines them into a single visual percept. This happens even if the match isn't perfect, as long as the disparity stays within a tolerable range. The key distinction here is that sensory fusion is purely a cortical process. It doesn't require eye movements. It's about how the brain interprets and merges the incoming signals once they arrive, not how the eyes get the images there. Now we shift from sensory fusion to motor fusion, which is how the eyes actively help maintain single vision. Motor fusion is made up of vergence eye movements that keep images falling on corresponding retinal points. When small misalignments exist, whether they're natural, like a heterophoria, or artificially created, like with prisms, motor fusion steps in to correct them. Fusional vergence allows the eyes to move just enough to realign the images when they're displaced on the retina. For example, when a base-out prism shifts images outward, fusional convergence brings the eyes in so single vision is maintained. So while sensory fusion is about how the brain combines images, motor fusion is about how the eyes move to make that combination possible.
Finally, we get to stereopsis, which represents the most advanced use of binocular vision. Stereopsis is the perception of relative depth that comes from horizontal differences between the images seen by the two eyes. It's the highest level of binocular cooperation, building on both sensory and motor fusion. The amount of retinal disparity that produces stereopsis is slightly wider than Panem's area, meaning the brain can extract depth information even when images aren't fused into a perfectly single percept. When disparity falls on the nasal retina, the brain interprets the object as being farther than the point of fixation. When disparity falls on the temporal retina, the object is perceived as being closer. Stereopsis doesn't require images to be perfectly centered or symmetric, and it can occur even when objects aren't on the midline. Developmentally, stereoscopic vision emerges early, with stereo acuity reaching about 60 arc seconds by 5 to 6 months of age. Before moving on, this slide helps clear up a very common misunderstanding about what stereopsis actually is. Think of stereopsis as a special kind of depth vision that only works when both eyes are used together. Because your eyes are a little bit apart, each eye sees the world from a slightly different angle. Your brain compares those two pictures and uses the tiny differences to figure out what is closer and what is farther. That's stereopsis. But depth perception is bigger than that. Even with one eye closed, your brain can still judge distance by using clues like which object overlaps another, which one looks smaller, how shadows fall, how things move when you turn your head, and how lines in the world seem to shrink into the distance. That's why someone with vision in only one eye can still have very good depth perception, even though they don't have stereopsis. This slide is reminding you that stereopsis is just one tool the brain uses to understand depth, not the whole toolbox. This slide zooms out and reminds us that binocular vision isn't just an eye problem, it's a wiring problem in the brain. To explain this simply, think of each eye as sending half of its information to each side of the brain. At the optic chiasm, some of the optic nerve fibers cross over. That crossing is essential because it allows information from matching parts of the two retinas to end up in the same place in the brain. Because of this decussation, signals from corresponding retinal areas can travel together through the optic tracts, stop at the lateral geniculate body, and then continue on to the visual cortex. That shared routing is what makes binocular vision and stereopsis possible in the first place. Once the signals reach the visual cortex, the brain doesn't just stack them on top of each other. It compares them, combines them, and tweaks them using multiple inputs. That's where single vision, fusion, and depth perception are actually built. Without this precise wiring, the eyes could be perfectly aligned and still never work together properly.
This slide marks the transition from anatomy and perception to development, how the visual system is actually built over time. Early in pregnancy, the retina makes far more ganglion cells than it will ever need. Most retinal ganglion cells are produced between about 8 and 15 weeks of gestation, and their numbers peak around 18 weeks, reaching more than 2 million. That's much higher than what we see in adults. After that point, the system starts pruning itself. Beginning around week 30, Many of these ganglion cells undergo programmed cell death over several weeks, and that process continues at a slower pace into the early months after birth. By adulthood, only about 1 to 1.5 million ganglion cells remain. This pruning is essential. Removing excess ganglion cell axons sharpens the wiring between the retina and the lateral geniculate body, refining topography and specificity. In other words, it's how blurry, messy early wiring becomes the precise visual system needed for binocular vision and stereopsis. This slide emphasizes that vision is still under construction after birth, especially at the level of the retina and fovea. Even though a baby is born with eyes that look structurally complete, visual function continues to mature after birth through major anatomic changes. At birth, the fovea is not yet specialized. It still contains multiple inner retinal cell layers, and cone density is relatively low. Because of that immature foveal structure, newborn visual acuity is very poor, on the order of 2400. Over the first few years of life, photoreceptors gradually redistribute within the retina. Cones migrate towards the center, and the inner retinal layers are displaced away from the fovea. As this happens, foveal cone density increases dramatically by about 5-fold until the adult configuration is reached. In simple terms, the fovea starts out crowded and inefficient, and over time it reorganizes itself into a tightly packed high-resolution center that can support fine visual acuity and binocular vision.
This slide shifts our attention from the retina to the brain, and it reinforces how long visual development really takes. At birth, the central visual pathways are still immature. The optic nerves and visual white matter are not fully myelinated, which means signals travel more slowly and less efficiently than they will later in life. Myelination ramps up quickly during the first 2 years, then continues more gradually through much of the first decade. The lateral geniculate body also starts out underdeveloped. Its neurons are only about 60% of their adult size at birth, and they continue to grow over the first couple of years. Beyond size, connectivity is still being refined. In the visual cortex, especially the striate cortex, synapses are initially overproduced. Over many years, these connections are selectively strengthened or eliminated. Synaptic density gradually drops by about 40%, reaching adult levels around 10 years of age. The big takeaway is that binocular vision depends on a long window of brain maturation. The visual system isn't just turned on at birth, it's slowly tuned over years through myelination, growth, and pruning, which is why early visual disruptions can have lasting effects.
This slide pulls everything we've talked about so far into a clear clinical message. During development, the visual system expects normal, balanced input from both eyes. When that input is abnormal, whether from visual deprivation, anisometropia, or strabismus, the entire retinogeniculocortical pathway can be altered. Importantly, studies in animal models show that amblyopia is not primarily a problem of the eye itself. The eye can be structurally normal. The real changes occur in the visual cortex, where abnormal input reshapes cortical organization. Even abnormal sensory input alone, without any structural eye disease, is enough to disrupt normal cortical anatomy. In simple terms, the brain wires itself based on what it sees. If the visual experience is distorted or unbalanced during development, the brain adapts to that abnormal input, and those adaptations can become permanent if not corrected early.
This slide gets very specific about where visual deprivation actually causes damage. If one eye is deprived during development, the eye itself shows very little structural change. The retina and globe can look essentially normal, which is why amblyopia can be so misleading on exam. At the level of the lateral geniculate nucleus, the layers connected to the deprived eye do shrink, but only slightly. And importantly, LGN cells can recover their responsiveness quickly once visual stimulation is restored. That tells us the LGN is not where the main problem lives. The biggest and most lasting changes occur in the striate cortex. Visual deprivation profoundly alters cortical organization, shifting ocular dominance and disrupting normal binocular integration. That's why the cortex, not the eye or the LGN, is considered the primary site of dysfunction in amblyopia. Clinically, this reinforces a key point.
Amblyopia is a disorder of cortical development driven by abnormal visual experience, and its treatment is fundamentally about restoring appropriate input to the brain during a limited developmental window.
This slide gives you visual proof of what we've been talking about, and it's one of the most important experiments in visual neuroscience. These images show the visual cortex of monkeys, specifically the ocular dominance columns. Think of them as stripes in the brain, where input from the left eye and right eye normally take turns. In a healthy system, those stripes are about the same width, meaning both eyes get equal representation in the cortex. In the image on the left, that's exactly what you see. The monkey had normal vision in both eyes, so the stripes from each eye are evenly spaced and balanced. The image on the right shows what happens when one eye is closed early in life. One eye was sutured shut, so the brain barely got any input from it. Over time, the stripes connected to the open eye got much wider, and the stripes connected to the closed eye shrank down dramatically. The easiest way to think about this is like a tug of war inside the brain. The eye that sends clearer, stronger signals wins more space. The eye that doesn't get used loses territory. Nothing is wrong with the closed eye itself. The brain just rewired itself to favor the eye that was doing the work.
This slide explains why those cortical changes happen by framing vision as a competition. When one eye is deprived early in life, the ocular dominance columns connected to that eye shrink dramatically. The two eyes are essentially competing for space in the visual cortex, and the eye with stronger, clearer input wins more synaptic territory. As the deprived eye loses ground, the non-deprived eye doesn't just stay the same, it actively expands. Its cortical connections grow into the space that the deprived eye gives up, with its terminal arbors spreading into that unused territory. But an important clinical point is that this expansion doesn't create supervision. Even though the open eye occupies more cortical space, visual acuity does not exceed normal limits. More cortex does not mean better than normal vision. Functional imaging reinforces this. PET studies show reduced cortical blood flow and glucose metabolism when the amblyopic eye is stimulated, reflecting reduced cortical engagement. And because monocular deprivation disrupts binocular competition so severely, very few binocular neurons remain. The big takeaway is that amblyopia is not passive loss. It's active cortical reorganization driven by competition. One eye doesn't just fall behind, it gets pushed out.
This slide pulls together everything we've discussed about development, deprivation, and competition, and it shows how different visual experiences lead to very different cortical outcomes. Start at the top. At birth, the visual cortex is not yet strongly committed to either eye. Inputs from the right and left eyes overlap a lot, and many cortical cells can respond to either eye. The system is flexible and still waiting for experience to shape it. In the normal 6-month-old, visual experience from both eyes is balanced. As a result, the cortex organizes itself so that about half the neurons prefer the right eye and half prefer the left, with a healthy population of binocular neurons in between. This is what normal binocular vision looks like at the cortical level. Now look at the strabismus example. Even without amblyopia, misalignment disrupts fusion. The cortex responds by reducing binocularity. Neurons still respond to one eye or the other, but far fewer respond to both. The eyes are both represented, but they're no longer working together. Finally, look at amblyopia from deprivation. When one eye is deprived early, the cortex becomes dominated by the non-deprived eye. Most neurons respond almost exclusively to the stronger eye, and binocularity is nearly lost. The deprived eye still sends signals, but very few cortical cells listen. This slide is where everything we've talked about suddenly becomes time-sensitive. The visual system has what's called a critical period, a window during early life when the cortex is especially plastic and highly responsive to visual experience. During this period, abnormal input can dramatically reshape cortical organization, but the flip side is that those changes are still reversible if normal visual input is restored in time. While the critical period is open, reversing deprivation by clearing a visual access obstruction or restoring balanced input can allow ocular dominance columns and cortical function to recover.
the brain is still willing to reassign territory. Once that critical period closes, that flexibility drops off sharply. Simply reopening a deprived eye later does not restore normal ocular dominance columns or binocularity. The cortex has already committed to a pattern, and it resists change. Clinically, this is why visual deprivation amblyopia is so dangerous. Dense media opacities like congenital cataracts or significant eyelid occlusion can rapidly produce profound amblyopia if they occur early. The deprivation doesn't have to be subtle or prolonged. Early and severe deprivation can permanently alter cortical development in a short amount of time. The takeaway is stark but important. Amblyopia isn't just about how bad the vision is. It's about when the abnormal input occurs. Timing determines reversibility.
This slide contrasts how different types of amblyopia form and when they do. Anisometropic amblyopia develops from chronic optical blur. Because one eye is consistently defocused, cortical neurons driven by that eye become less sensitive, especially to fine detail. This process is gradual, so the critical period occurs later than in strabismic amblyopia. Meridianal, or astigmatic amblyopia, doesn't appear in the first year of life and may not show up until around 3 years of age. Strabismic amblyopia is caused by conflicting foveal input rather than blur. To avoid diplopia, the brain suppresses one eye, leading to early cortical changes. Its critical period begins much earlier, around 4 months of age. Alternating fixation can preserve acuity in each eye, but binocularity is still lost. In short, anisometropic amblyopia is slow and blur-driven, while strabismic amblyopia is early and conflict-driven. This slide is the big picture takeaway for the entire chapter. The visual cortex doesn't develop correctly on its own. It requires appropriate sensory stimulation. Normal input builds normal cortical architecture. When sensory input is abnormal during development, the cortex adapts to that abnormality. Those adaptations are structural, not just functional, and they can persist long after the original problem is gone. And this idea likely extends beyond vision. It suggests that early childhood is a critical time for all sensory systems, where a rich, balanced sensory environment helps shape healthy brain development. In short, experience doesn't just influence the brain, it builds it. This slide marks the transition to what happens when binocular vision breaks down. When there is a manifest ocular deviation, the eyes are no longer aligned, and corresponding retinal points stop looking at the same object in space. Each eye is sending a clear signal, but those signals no longer match. That mismatch puts the patient at risk for two related but distinct problems. One is visual confusion, where two different objects are perceived in the same visual direction. The other is diplopia, where the same object is perceived in two different directions. From here on, the chapter is really about how the visual system responds to this problem, whether by adapting, suppressing, or reorganizing to avoid constant confusion and double vision. This slide separates two related but very different sensory phenomena. Visual confusion happens when two different objects in the world fall onto corresponding retinal points in the two eyes. Because corresponding points normally signal the same direction in space, the brain tries to place both objects in the same location. Clinically meaningful confusion is actually uncommon, and when it does occur, it's usually limited to extrafoveal retina. The foveae are simply not built to perceive two dissimilar objects at the same time. At the fovea, the system behaves differently. Instead of confusion, you get retinal rivalry. When each fovea is stimulated by a different image, the brain doesn't merge them. Instead, perception alternates. One image dominates briefly, then the other takes over. So the distinction is this. In the periphery, mismatched images can produce confusion. At the fovea, mismatched images produce rivalry. The brain avoids seeing two things at once by rapidly switching between them. This picture is showing you what retinal rivalry feels like. In the first box, the left eye is seeing one pattern of lines. In the second box, the right eye is seeing a different pattern of lines. Both images are clear, but they don't match. When your brain tries to use both eyes at the same time, it can't combine those two patterns into one picture. Instead of blending them, your brain starts to switch back and forth. For a moment, you mostly see the left eye pattern.
Then it fades and you mostly see the right eye pattern. This switching happens over and over again. The third image is what that feels like. It looks messy and unstable, almost like the picture is moving or flickering because your brain is rapidly alternating between the two inputs. The easiest way to think about it is this. Your brain can't decide which picture to believe, so it keeps changing its mind. That back and forth switching is retinal rivalry. This slide introduces diplopia, which is what happens when the visual system can no longer keep one object looking like one object. Diplopia means seeing double, and it usually happens when the eyes become misaligned after the visual system has already learned how to work together. Because the eyes aren't pointing at the same place, the same object lands on the center of vision in one eye, but on an off-center spot in the other eye. Your brain doesn't know how to fuse those two images because they're too far apart to fall within Panem's area. So instead of one picture, you see two. The object feels like it's in two different places at the same time. Think of it like this. One eye is looking straight at the object, and the other eye is looking a little to the side. Your brain gets two pictures that don't line up, so it shows you both. The picture from the eye that's looking straight at the object is clearer, and the other one looks blurrier. Whether someone actually notices double vision depends on a few things: how old they were when it started, how long it's been happening, and how aware they are of the images. Younger children are often able to turn off the extra image without realizing it, which is called suppression. Adults usually can't do that, which is why acquired strabismus in adults almost always causes bothersome diplopia.
This slide introduces a rare but very important concept. What happens when the brain can neither fuse images nor turn one off? Central fusion disruption, also called horror fusionis, means the visual system has lost the ability to combine images from the two eyes, and at the same time cannot suppress one of them. The result is constant, intractable diplopia. In simpler terms, the brain is stuck. It can't merge the two images into one, and it also can't ignore either image, so the person is forced to see double all the time. This tends to occur in adults or visually mature children, because younger children usually still have the ability to suppress one eye. Common triggers include traumatic brain injury or restoring vision after a long period of monocular deprivation, such as correcting long-standing aphakia. In those cases, visual input returns, but the cortical machinery needed to handle binocular input is no longer intact. Thinking simply, your brain has two backup plans: either blend the pictures together or shut one off. In horror fusionis, both backup plans are broken. That's why the double vision is severe and why treatment is so difficult. The key clinical message here is that once normal fusion mechanisms are lost in a mature visual system, they are extremely hard to rebuild.
This slide highlights how the developing visual system protects itself in strabismus. To avoid constant diplopia and visual confusion, the immature visual system adapts by using suppression and anomalous retinal correspondence. These mechanisms reduce discomfort by either ignoring input from one eye or redefining which retinal planes are treated as matching. These adaptations are not pathologic by default. They are responses to misalignment. Importantly, they only develop in an immature visual system and require binocular input to form. In short, children adapt to strabismus to maintain single vision, but they do so at the expense of normal binocular function.
This slide defines suppression and explains why it exists. Suppression is an active change in visual sensation where the brain prevents the image from one eye from reaching awareness during binocular viewing. It's not that the eye stops seeing, the brain stops listening. There is a normal physiologic form of suppression that keeps us from noticing physiologic diplopia for objects outside Panem's area. Pathologic suppression is different. It develops in response to discordant images, most commonly from strabismus, anisometropia, or media opacity, and it serves to eliminate constant diplopia. This is an active binocular adaptation that only occurs in the immature visual system. In a patient with strabismus and normal retinal correspondence, the absence of diplopia essentially proves suppression, assuming the sensory pathways are intact. Clinically, suppression isn't subtle. We can demonstrate it with simple office tests, which becomes important when evaluating binocular potential and amblyopia risk.
This slide breaks suppression down by where in the visual field it acts and what problem it's solving. Central suppression blocks the foveal image from the deviating eye from reaching awareness. Its main purpose is to prevent visual confusion, which would occur if two different objects were perceived in the same visual direction. Peripheral suppression works differently. It blocks the peripheral retinal image from the deviating eye that would otherwise correspond to the fovea of the fixing eye. By doing this, it eliminates diplopia. A critical point is timing. If strabismus develops after visual maturation, peripheral suppression does not develop. That's why adults with acquired strabismus usually experience persistent diplopia. As a result, adults cannot suppress the second image neurologically. To eliminate diplopia, they must physically close or occlude the deviating eye.
This slide classifies suppression based on when it happens and how stable it is over time. In non-alternating suppression, the same eye is consistently suppressed while the other eye dominates. Because one eye is chronically ignored, this pattern carries a higher risk of amblyopia. In alternating suppression, suppression switches back and forth between the two eyes. Since neither eye is consistently shut down, amblyopia is much less likely to develop. Facultative suppression only occurs when the eyes are misaligned and disappears when alignment is restored. A classic example is intermittent exotropia, where stereopsis can be present during periods of alignment. Constant suppression is present regardless of whether the eyes are aligned or deviated. In these cases, a suppression scotoma is always present. That scotoma may be relative, meaning some visual sensation remains, or absolute, meaning there is no perception of light. The key idea is that the more consistent and one-sided the suppression, the greater the risk to visual development.
This slide is about what to do once suppression is present, and just as importantly, what not to do. Management focuses on restoring appropriate visual input and proper alignment, not on forcing the brain to stop suppressing. The first step is always accurate refractive correction, because the cortex can't relearn binocular vision if one eye is still delivering a degraded image. If amblyopia is present, treatment targets that directly, usually with occlusion or pharmacological penalization, to strengthen input from the weaker eye. Separately, aligning the visual axes, whether with glasses, prisms, or surgery, allows the same object to stimulate corresponding retinal points in both eyes, which is the foundation for any binocular recovery. A critical warning comes at the end of this slide. Anti-suppression orthoptic exercises are generally not recommended. Suppression is an adaptation that prevents diplopia. Removing it without restoring stable fusion can unmask severe intractable double vision. The key idea is this: suppression should be resolved indirectly by fixing the visual conditions that caused it, not attacked head-on. Forcing awareness without restoring alignment and fusion can do real harm. This slide introduces anomalous retinal correspondence, or ARC, which is another way the developing brain adapts to strabismus. ARC is a cortical sensory adaptation that allows some level of binocular cooperation even when the eyes are visibly misaligned. Instead of suppressing one eye completely, the brain rewires which retinal points are treated as matching. In ARC, the object a person is looking at lands on the fovea of the fixing eye, but on a peripheral retinal point in the deviating eye. The brain then treats those 2 points as if they correspond to each other. Because of that remapping, the person does not experience diplopia. This is why ARC is considered a better functional state than total suppression. Both eyes are still being used, even though normal sensory development has been partially replaced by this abnormal mapping. ARC doesn't happen all at once. It develops gradually and often incompletely, and the longer a deviation is present, the more deeply ingrained it can become. The window for ARC development likely extends through much of the first decade of life. The key idea is that ARC is the brain choosing cooperation over silence, maintaining single vision by changing the rules of correspondence rather than shutting an eye off entirely. This slide explains a situation that feels surprising to patients, but makes sense once you understand ARC. Paradoxical diplopia can happen when anomalous retinal correspondence is still present after the eyes are surgically realigned. The muscles are fixed, but the brain is still using the old sensory map. For example, a patient who had an esotropia may end up straight or nearly straight after surgery, yet report crossed diplopia when looking at central or near central targets. That happens because the brain is still pairing the fovea of one eye with a peripheral retinal point in the other, even though the eyes are now aligned. In other words, the eyes have moved, but the sensory wiring hasn't caught up yet. This diplopia usually improves on its own as the brain gradually updates its sensory mapping to match the new alignment. Most cases resolve over days to weeks. In rare situations, the old mapping is more deeply ingrained and symptoms can last longer. The key idea is that paradoxical diplopia reflects persistence of preoperative sensory adaptation, not a surgical failure.
Let's walk through this picture in a simple, intuitive way. Before surgery, this patient had an esotropia, so the brain adapted by using anomalous retinal correspondence. Instead of using the true center of vision in the deviating eye, the brain picked a nearby spot called a pseudophobia and treated it like the center. That's how the patient avoided double vision before surgery. Now comes the key moment. A prism or surgery straightens the eyes so they're pointing at the same target. The light from the pen light is now moved onto the true fovea of the previously deviating eye instead of the pseudofovea. But the brain is still using the old map. The brain still thinks the pseudofovea is the center. So when the image suddenly lands on the real fovea, the brain interprets it as being in the wrong place. Because of that mismatch, the image is perceived as coming from the opposite side, which creates crossed diplopia. This is why the diplopia is called paradoxical. The eyes are straighter than ever, but the brain is still using old rules. Over time, the brain usually relearns the correct map, and the double vision goes away.
This slide explains what we're really testing when we look for anomalous retinal correspondence. ARC testing isn't just about eye position. It's about how the patient actually uses their eyes in everyday vision and whether any normal retinal correspondence is still present. Because ARC is a sensory adaptation, its depth can vary. Some patients can show both normal retinal correspondence and anomalous retinal correspondence, depending on how you test them. That's why different tests can give different answers. Tests that closely mimic natural viewing conditions are more likely to reveal ARC because they allow the patient to use their habitual sensory adaptations. In contrast, highly dissociative tests tend to break binocular cooperation and often produce a normal retinal correspondence response, unless ARC is very deeply ingrained. If a patient still shows anomalous localization even on a highly dissociative test, that suggests the ARC is well established and deeply rooted. The key takeaway is that ARC is not all or none. How it shows up depends on how much you disrupt the patient's natural binocular viewing conditions.
I want to quickly orient you to how these ARC tests are organized. This slide is ordered from the most dissociative tests at the top to the least dissociative at the bottom. Dissociation means how much the test separates the two eyes and disrupts natural binocular viewing. The Worth 4-dot test is highly dissociative because colored filters strongly isolate each eye, so it often reveals what the visual system can do rather than what it normally does. The red glass test is similar, but the amount of dissociation depends on how dark the filter is. As the filter density increases, the test becomes more dissociative. The amblyoscope, or synoptophore, sits in the middle. It allows controlled binocular viewing, but it's still an artificial situation that doesn't fully reflect everyday vision. Bogolini striated lenses are the least dissociative and most natural. The patient views a real target in normal lighting with minimal interference. Because of that, ARC detected on Bogolini testing is usually the most clinically meaningful, as it reflects how the patient actually uses their vision in daily life. So as you look at these tests, remember the key principle. The less dissociation, the closer you are to the patient's true functional binocular state. Before interpreting any ARC test, there are a few principles you have to keep straight. First, anomalous retinal correspondence is a binocular phenomenon, which means it can only be tested when both eyes are viewing at the same time. If you test one eye at a time, you are no longer testing ARC. Second, ARC is not the same thing as eccentric fixation. Eccentric fixation is a monocular problem. It's about where one eye is aiming, whereas ARC is about how the two eyes are linked together cortically. This distinction matters because tests that rely on separate foveal stimulation can be misleading if eccentric fixation is present. In those cases, what looks like abnormal correspondence may simply be the amblyopic eye using a non-foveal point to fixate.
So the key takeaway is this: eccentric fixation can significantly affect ARC test results, and if you don't account for it, you can draw the wrong conclusion about the patient's true binocular sensory state.
This figure compares 3 different sensory outcomes in strabismus, and it's a great way to see how the brain deals with misalignment. On the left is normal retinal correspondence. The eyes are misaligned, but the brain has not adapted. The same object falls on the fovea of one eye and an extrafoveal point in the other, so the patient experiences diplopia. 2 retinal locations are being treated as different, and the brain reports 2 images. In the middle is suppression. The geometry is the same, but now the brain actively ignores the image coming from the deviating eye. By suppressing the conflicting retinal area, diplopia is eliminated, but binocular vision is sacrificed. On the right is anomalous retinal correspondence. Here, the brain takes a different approach. Instead of ignoring the deviating eye, it rewires visual direction. The fovea of the fixing eye is paired with a non-foveal point, the pseudofovea of the deviating eye. Because those 2 points are now treated as corresponding, the patient perceives a single image without diplopia, even though the eyes remain misaligned. So the key idea is this: suppression removes one image, while ARC rewires correspondence. Both eliminate diplopia, but only ARC preserves some degree of binocular cooperation.
Let's introduce monofixation syndrome. Monofixation syndrome isn't really about eye position, it's a sensory adaptation. These patients can fuse peripherally, but they've lost bifoveal fusion. The reason is a small central suppression scotoma in the non-fixating eye, which knocks out fine foveal fusion while leaving peripheral fusion intact. So they don't get true stereopsis, but they also don't get constant diplopia. They sit in this middle ground, stable, comfortable vision, but limited depth perception. You'll also hear the term microtropia, which refers to a very small angle strabismus. Clinically and functionally, microtropia and monofixation syndrome overlap so much that they're often used interchangeably. The key idea is this: monofixation syndrome is peripheral fusion without central fusion, created by a tiny central suppression zone.
Now let's talk about what monofixation syndrome actually looks like clinically. These patients may not have an obvious eye turn at all, or they may have a very small deviation, typically less than 8 prism diopters. When a deviation is present, it's most often an esotropia, though exotropia or even hypertropia can occur. They usually have some stereopsis, but it's reduced. Fine depth perception is lost, even though peripheral fusion is preserved. Amblyopia is common, which fits with the presence of a small central suppression scotoma. Interestingly, monofixation syndrome is often considered a favorable sensory outcome after infantile strabismus surgery because it provides comfortable single vision without diplopia. You'll also see it in a significant minority of patients with intermittent exotropia. Importantly, monofixation syndrome doesn't always require obvious strabismus. It can occur as a primary condition, especially in patients with anisymmetropia or macular pathology, where the sensory system adapts even without a large motor misalignment.
Now, let's talk about how we actually diagnose monofixation syndrome. The diagnosis hinges on demonstrating 2 things at the same time: absent bifoveal fusion and preserved peripheral fusion. In other words, the patient cannot fuse with both foveae, but they can still fuse using peripheral retinal elements. A key requirement is documenting a macular scotoma in the non-fixating eye, and this has to be shown under binocular viewing conditions, not monocular testing. Stereoacuity testing is essential. Any amount of gross stereopsis confirms that peripheral fusion is present. Typical stereoacuity in monofixation syndrome falls in the range of about 200 to 3,000 arc seconds, which is much worse than normal, but still measurable. Some patients may have no measurable stereopsis at all, which means you need to rely more heavily on fusion testing. Peripheral fusion is best assessed with tests like the Worth 4-dot and Baggellini striated lenses, which closely simulate natural viewing conditions. Finally, it's important to remember that fine stereopsis, better than about 67 arc seconds, requires true bifoveal fixation. If you see fine stereopsis, monofixation syndrome is essentially ruled out. Finally, let's talk about management of monofixation syndrome. The first priority is treating amblyopia.
typically with occlusion, but only if it's clinically significant. The goal here is visual acuity, not restoring bifoveal fusion, which generally isn't achievable. Most patients with monofixation syndrome are stable and asymptomatic, especially in childhood. However, it's important to know that monofixation can decompensate in adulthood, leading to new onset diplopia. If decompensation occurs and symptoms are significant, strabismus surgery may be required. In this setting, surgery is aimed at restoring comfortable alignment and peripheral fusion, not normal bifoveal fusion. So overall, management is conservative. Treat amblyopia when present, monitor for decompensation, and intervene surgically only when symptoms demand it. Let's wrap this up by stepping back and asking a simple question. What does the brain do when the eyes don't line up, but double vision would be unacceptable? The brain has three main strategies. The first is suppression. In this case, the brain simply ignores the image from one eye. That successfully prevents double vision, but at a cost. Over time, the ignored eye may fail to develop normally, leading to amblyopia. This strategy is most common in young children. The second strategy is anomalous retinal correspondence, or ARC. Here, the brain doesn't ignore an eye, it rewires its internal map. Misaligned eyes are reassigned new matching points so they can still work together. Both eyes are used, but the spatial map is inaccurate. This only works while the brain is still developing. The third strategy is monofixation syndrome. In this state, the brain uses one eye for sharp central vision and both eyes together for peripheral vision. Some depth perception is present, but it's reduced. Importantly, this arrangement is very stable, and many patients are completely asymptomatic. So overall, when alignment fails, the brain adapts. It can ignore input, remap input, or divide visual labor, and each solution has different consequences for vision and development.
This slide explains why strabismus surgery affects these sensory states so differently. With suppression, there's nothing new for surgery to disrupt. One eye was already being ignored by the brain, so straightening the eyes doesn't suddenly create double vision. With anomalous retinal correspondence, surgery fixes the eye position but not the brain's wiring. The eyes are straight, but the cortex is still using the old abnormal map. That mismatch is why these patients can experience temporary diplopia after surgery until the brain adapts. With monofixation syndrome, central fusion was never present to begin with. The brain already relied on one eye for fine detail and both eyes for peripheral vision. So surgery improves alignment without creating a new sensory conflict. In short, surgery changes the mechanics, but symptoms depend entirely on how the brain was solving the problem beforehand.
Thank you for your attention. I hope this helped clarify how the visual system develops, how the brain adapts to misalignment, and why suppression, anomalous retinal correspondence, and monofixation represent fundamentally different solutions to the same problem. Understanding these sensory adaptations is essential, not just for exams, but for predicting symptoms, counseling patients, and anticipating what surgery can and cannot fix. Thanks again.